Hi and welcome back to Blue Light Bites. Yes, these medical munchies. These are the pork scratchings of clinical education. The good news is they don't break your teeth and there aren't any hairy bits on them either. I'm Tony, I'm an ambulance doctor and I've been a medical educator for a lot of years. So it's great to have you along with me because today we are going to be talking about headaches. Yes, headaches. We are going to be trying to tease out the tension from the terrible. Now folks, the good news is there are about 150 types of headaches, but we will only be discussing probably about 149 of them. Right, well, a lot of this work has come from the British Association for the Study of Headaches, which must be a really interesting association to belong to, and we can shorten it by the acronym of BASH. How very appropriate. Now, in BASH, they talk about dividing headaches into two categories, primary and secondary. Yes, primary and secondary. Primary headaches are the sweet, innocent, nice little ones that you want to pat on the head and send on their way. Secondary headaches, well, they are a little bit different, aren't they? They are rather surly, they are rather smelly, and they are rather spotty. So what is the difference between primary and secondary headaches? Well, a primary headache is when the headache itself is the condition. It is the disease. Whereas in a secondary headache, it's something else, something big and bad and nasty is causing the headache. It's not a primary condition, it is secondary. And by the way, if you're wondering why the paramedic there has a simple annoyee rather than an analogy, it's because I had about 20 attempts to change this AI slide, by which time I had a secondary headache because it was caused by artificial intelligence. Beware, AI can't be good, can it? Okay, here's the thing, back in my day, headaches were always splitting. Have you noticed that now they are banging? I don't get that. In modern speak, I thought banging meant good, and there's nothing good about a headache. Guys, I'm not judging, I'm just saying. Okay, primary headaches. We're moving on. Primary headaches. Tension type headache, migraine and cluster headaches. These are the three types of primary headache. We are going to talk about each of them in turn. Tension headaches. This is by far and away the most common. People say it feels like their head is in a vice. Now, why should somebody say that? Because I bet most people haven't tried it. But that's what they say, don't they? Because the pain is bilateral. In fact, it's all around. It feels like a tight band. It's a dull, aching pain, which by and large doesn't affect you that much. You don't tend to throw up. You're not that bothered about light and noise. And it's sort of mild to moderate, but not that awful. Tension headaches can last from just a few minutes to, well, several days really. And tension headaches are caused by, well, muscle tension. Muscle tension in the neck. They're also caused by stress. Stress, of course, can cause muscle tension in the neck. They're caused by poor posture. Muscle tension in the neck again. And they're caused by eye strain because you should have gone to Specsavers. They can be caused by a lack of sleep, a lack of fluid, a lack of meals, and too much caffeine. And also loud noises and other environmental factors. So the most amazing thing is that, well, everybody in the ambulance service doesn't have a permanent tension headache. Okay, we're done with tension headaches. Let's move on. And now we're going to whisper because we're talking about migraines. Yes, leave me alone type of migraines. Migraines are not funny, are they? If you've had a migraine, you know it's no laughing matter. Typically, it's going to affect one side of the head, often the front, and it is typically unilateral, but it don't be caught out because you can get bilateral migraines if you're extremely lucky. And with the migraines comes a sensitivity to light. Yes, light and loud noises. You don't like them. You want to go and sit in a dark room. You want to go to sleep, but you can't go to sleep because you're feeling sick and you're throwing up. And if you've got a good going migraine, you're probably not going to want to do anything particularly physical. Some people get an aura before they get a migraine. They may get a visual disturbance, flashing lights or zigzag lines or blind spots. And they may have other prodrome features like feeling tired, feeling moody, craving for food, not being able to concentrate. And migraines can be triggered by lots of things. Classically, it's cheese and chocolate and wine and caffeine, but stress, poor sleep, hormonal changes can cause migraines, typically in the menstrual cycle when estrogen is low. Migraine attacks can last anywhere from a few hours to a few days, and they can be associated with a hemiplegia, so they can be easily mistaken for a stroke. But if people have got the hemiplegia, you're not going to say it's just a migraine, you're going to take them in, aren't you? Let's talk about something different, something nutty. We're going to talk about cluster headaches. Yes, cluster headaches. Now, cluster headaches are very, very rare, but they're also very, very nasty. They are severe. Some people call them suicide headaches because people can be driven to suicide by this severe pain. It tends to be around or behind the eye. It tends to be on one side, and it is a rotten pain. It's horrible pain. It's the worst pain you can imagine. And with it can come various autonomic features such as tearing. They have runny eyes. They have red eyes. They have a runny nose, or maybe it's just blocked. They can get facial sweating, and they can get droopy eyelids to make them look like they're having a stroke, and they tend to be restless because they are in so much pain. And these attacks tend to be short-lived, but they come in little clusters. Yes, they're episodic attacks. They come together, and they can occur at certain times of the day. Classically, this is at night, and they wake people up from sleep. And they tend to be more common in men than women. There are some triggers, but they're really very unpleasant. And most patients, well, if they're getting them, they'll have seen a neurologist and they'll have a diagnosis. Whew! I don't know about you, but I have seen too many pictures of unhappy people. People grimacing, people looking miserable. Let's have something nice and smiley, shall we? Relax. And we'll move on. Okay, we're on to secondary headaches. Yes, remember the spotty, smelly, surly ones? These are the ones that are caused by an underlying disease. And typically they are of 4 or 5 types. Sinus headaches, medicine overuse headaches, trauma, so that's concussion or more serious head injury, high blood pressure, and other bits and bobs, which we'll talk about later. Sinuses. Okay, sinuses. Sinuses are air pockets within the skull. They're a great design idea because it makes the skull lighter so we can carry our heads around with us. But the bad news is they get blocked, and when they get blocked, they can get infected. And when they get infected, they hurt. Yes, they hurt a lot. There's facial pain. There's that pressure. It tends to be where the sinus that's infected is. So it could be in the forehead. It could be in the cheeks. It could feel deeper between the eyes or around the eyes. They're often got a very blocked nose, or they may have a nasal discharge, and that tends to be horrible green gloopy stuff, and sometimes it is rather pongy as well. Yes, an offensive nasal discharge. But the good news is if you have sinusitis, you probably can't smell it. It's just the rest of us that have to put up with it. They tend to get a headache. That headache is worse when they bend forwards, and all that horrible gloopy muck also goes down the back of the throat. So they may have bad breath, they may wake up at night coughing, and they may have other symptoms as well, typically a fatigue or a fever or toothache. And sinusitis can last from anything up to a few weeks, and there are subacute and chronic types as well, but basically the ones we're most likely to see are going to be the acute sinusitis. Okay. So for sinusitis, people take medication, don't they? And medication is what they take for headaches in general. But unfortunately, some people take too much medication, too many painkillers, and they develop a thing called medication overuse headache. Quite simple to get. Basically, you take too many painkillers, then when you don't have a painkiller, you have a headache. So what you do? Yes, of course, you take another painkiller. And so the cycle carries on. You just go round and round in cycles and circles of misery. Yes, the circle of doom, but this circle of doom is not blue, and it can be broken, but only by stopping taking the medication. And when you stop taking that medication, you're going to feel rotten. You're going to feel rotten for quite some time. So it's a hard sell to get patients to do it. So when can you suspect medication overuse headaches? Well, if people are taking simple painkillers like paracetamol, ibuprofen and aspirin, it's if they're taking it for more than, say, 15 days in any 1 month. If they're taking something altogether posher, like opioids or triptans or ergotamines, then if they're taking more than 10 days per month, they are prone to medication overuse headaches. It's much more common than we think. Right. From common to concussion. Concussion caused, well, by minor head injuries. Minor head injuries that rattle the brain about in its box and cause a headache and dizziness, make people feel pukey. They don't like the light. They don't like the noise. They can't concentrate. They can't think properly. They're a bit moody. They feel tired and they feel all fogged up. And those concussion symptoms can last from anything up to a week to several months. Clearly, if someone has a more sinister head injury and a bleed on the brain, the symptoms are going to be much worse. We'll come on to that later. High blood pressure can cause headaches. It's got to be pretty high before you get headaches, but typically patients will feel a pulsating pressure in the head. Yes, it's going boom, boom, boom. Their vision can be blurred. And again, Specsavers, folks. They can be dizzy. They can feel sick. And then we'll talk briefly about homeostatic causes of headache. That sounds very posh, doesn't it? Homeostatic causes of headache. But basically, we've covered quite a bit of that already. Yes, it's dehydration. It's not enough fluid. It's not enough sugar. It's not enough caffeine when you're used to drinking too much of it. It's not enough sleep. And it's just a little bit too much stress. Not enough time in nature. Let's talk about carbon monoxide. Yes, carbon monoxide, the silent killer. Carbon monoxide, if someone is getting a throbbing headache, dizzy, nausea, tired, and some of the other things we've talked about, and the history doesn't quite go as you might expect, there's something weird going on here. There's something strange. Think carbon monoxide poisoning. Okay. Right, it's time. It's time to get down. It's time to get dirty. It's time to talk about sex. Now, sex causes headaches, folks. Sex causes headaches. Sometimes even the mention of the word sex can cause a headache. And when sex rears its ugly head, well, the pain in that ugly head can be intense. Yes, orgasm headaches. You might have had the best sex of your life, but you've also got the worst headache of your life. It's sudden, it's severe, it's a bang at the back of the head at orgasm, or maybe just before. Now, that obviously resembles subarachnoid hemorrhage. More on that later. Orgasm headaches tend to be short-lived. Yes, they're just a few seconds, but my lord, they are not a few seconds of bliss. No, they are not. And they can occur with any sort of sexual activity that is reaching orgasm, and they may well be recurrent. But the big message is, if it's the first time they've had it, treat it as a subarachnoid. They need to be in hospital. And many guidelines say you still need to do that until they've had 3. And if they've had 3 of these in a row, and they're all related to orgasm, well, you can probably tell the patient they have got orgasm headache. And maybe the best treatment would be a mug of cocoa, a good novel, and an early night. Night-night, darling. Whew. Right, well, I think we've had too much sex. It's time to get wholesome. It's time to take a trip to the mountains. It's time to sniff that morning air, to look at the pretty flowers, to look at the snow-topped peaks, and just to take a deep breath. But not too deep, because now we are into the serious situations. Yes, those serious things, those bad headaches, those worst imaginable headaches. What could be worse than that? Now, before I get too political, I must state that any views in these videos are purely my own and are not necessarily held by any organisation that I might work for. But hey guys, really? Infections. Let's talk about infections. Now, there's many viruses and bacteria that just love to cause headaches, and they do so in a really rather unpleasant way. Meningitis and encephalitis. Talking first about meningitis. Meningitis, when the wrapping of the brain gets infected, and that also includes the wrappings around the spinal cord. And as you know, you get a sudden onset of fever. The headache is severe. Patient can be nauseous, they can vomit, they don't like the light, mental status can be altered, they can be irritable, they can have a seizure. We all know the features of meningitis, don't we? And they have a rash. We'll come on to the rash in a moment. Encephalitis, well, encephalitis is when the squidgy bit in the brain box gets infected and inflamed. And basically the symptoms are the same. Fever, headache, altered mental status, seizures, blah-de-blah-de-blah. It doesn't matter which your patient has, whether it's going to be meningitis or encephalitis, they need to be in hospital. And if you're a long way from the hospital, they're going to need some antibiotic before they get there. Now, we know a lot about, or we talk a lot about the rash in meningitis, but many of us will never have actually seen it, which is a great thing, I guess. But the rash in meningitis can be very variable, and it can start with just a couple of little tiny spots, little petechial hemorrhages. They look like little bruises. If you press a glass on them, they don't go away. And then with time, and often that's quite a short time, these coalesce and they become bigger and bigger and bigger until you have a picture like that unfortunate one there on the far right, when clearly the patient is very sick. And by the time they have a rash like this, well, you really should have noticed the fact that they are big sick in many ways. Which leads us on, in a very happy way, to stroke. Yes, stroke, and by this we also include subarachnoid hemorrhage. These headaches in stroke are rapid of onset. They come on quickly and they're bad. Yes, they can be the worst headache of your life. In a subarachnoid, they are typically at the back of the head. It feels like somebody had thumped you. In fact, it's not uncommon to turn around to see exactly who that was. And they may be accompanied by signs of raised intracranial pressure, so nausea, vomiting, dizziness, weakness, numbness, difficulty speaking, visual problems, drowsiness, coma. Things that can cause strokes include giant cell arteritis. Now, this is something that you may not necessarily think about, but you really should be thinking about it in a new onset headache in anybody over the age of 50. Temporal arteritis is the big one here. This is where you get inflammation of large and medium arteries. Usually this is in the head, can be in other places too. These patients will get a new onset headache. Typically it's a temporal artery. If you look at that picture there on number 1 features, you'll see where the temporal artery is. Yes, it's in the temple, and you may even be able to palpate that artery, and it is tender. They are tender when you touch them. They are tender when they brush their hair. And when they're eating, well, the muscles of the jaw aren't getting enough blood, so you get claudication. A bit like angina, really, but this is angina in the jaw. They can get visual symptoms. They can get systemic symptoms where they feel pretty crappy, fever, fatigue, malaise. And they may also have polymyalgia, where you get stiffness in the shoulder girdle and in the hip girdle. Now, giant cell arteritis is a medical emergency because it can cause permanent visual loss, it can cause strokes, and it can cause aortic dissection and aneurysms. They need to be in hospital, they need blood tests, and they need early treatment with high-dose steroids. Brain tumours. Okay, last heavy slide, folks, the last heavy slide. Brain tumours. We know unwanted guests never follow the rules, do they? And brain tumour headaches don't follow the rules because they get worse. They get worse day after day after day, progressively worse day on day. They are persistent, they are progressive, they're often worse in the morning or when the patient lies down. They may be associated with vomiting. They may be associated with seizures. They may be associated with focal neurological abnormalities, behavioural changes, and if they're getting really big, the signs of raised intracranial pressure. So drowsiness, vomiting, facial nerve palsies, and if it's really bad, Cushing's triad, where the blood pressure goes up, the pulse goes down, and respirations become abnormal. So any headache, particularly if there is a history of some other type of tumour that might have metastasized to the brain, any headache which is getting worse day after day after day and is relentless, that is a red flag. Now, the key to all of these conditions is in the history, isn't it? It's in the questioning. In the pre-hospital phase, clinical examination isn't that useful. There are occasional things where features may suggest a serious type of headache, but by and large, it is the history that we are focusing on. While we've got Henry VIII there, let's talk about his cure for headaches. It was a very effective cure. Just ask Anne Boleyn or Catherine Howard. Right. So we've talked about the different types of headache, haven't we? And some of them are pretty hairy scary. But the good news, guys, is that most types of headache that you will encounter in your clinical practice are going to be tension type headaches. Probably about 65 to 70%. Then migraine will be the next biggie. Migraine, 20 to 25%. Secondary headaches, the ones that have some sort of underlying condition, well, they're much less frequent. Cluster headaches and the other primary headaches, well, they are very, very rare. So how are we going to tease them apart when we are dealing with a patient either by triage, using a video link, or face-to-face on the road? These are the red flags. Oh, yes, they are. And there's that annoying noise again that tells us these are red flags. These are the things to be very careful of. These are the things to look out for so you don't get caught out. Right, here we go. At number 1, we have sudden onset. Yes, that thunderclap headache. That headache that reaches its peak in seconds. It feels like a bang from behind or maybe in any other part of the head. The new headache over the age of 50. The headache that causes vomiting that isn't a normal migraine for the patient. Any progressive pattern of headache is an alarming thing, as is pregnancy and up to 6 weeks after pregnancy, because patients can still have preeclampsia and of course they are at risk of a venous sinus thrombosis. This is a blood clot deep within the brain. Any sign of neurological deficit, so if they're fast negative, let's take that again. If they are fast positive or MEND positive, then that is a concern. As are systemic symptoms. If it's anything more than, say, sinusitis or the common cold, be aware that the headache may have a serious underlying infection. So fever, chills, rash. Also, if there's any what we'd call B symptoms, so weight loss, night sweats, history of cancers, these also are red flag features. Also red flags are patients who bleed too much or don't fight infection well enough. So if they have a coagulopathy or taking blood thinners, or if they are immunosuppressed in any way, maybe with a biological medication or steroids, then they are at risk of a serious headache cause. And then positional headaches, so headaches that are worse when lying down or bending or Valsalva. Now, most patients won't do the Valsalva to see if their headache is serious, but what they will do is tell you that when they cough, when they sneeze, when they strain, when they pick something up, it hurts more. That is a danger sign. So we've had the red flags. Let's think about the green flags, shall we? Let's just relax a bit and remind ourselves that most causes of headache are benign. Yes, if the patient's headache has come on slowly, built up gently, follows a familiar pattern, gets better when they take medication, don't take too much of it though, isn't the worst one headache, and allows them to carry on as normal, the chances are it's no big deal. Just watch for those red flags, folks. If they haven't got any, the chances are you're fine. You're home and dry. And that brings us home and dry to the end of this edition of Blue Light Bites. I hope you've enjoyed it. As ever, I'll be back again in a month, and I think we'll probably talk about functional neurological disorder. Yes, we'll talk about FND. That'll be fun. Okay, until then, my friends, stay safe, keep listening, spread the word, spread the love, spread the link. I'll see you next time. Blessings.